Hello, everybody. I'm Professor Di Biase from the Albert Einstein College of Medicine in New York at Montefiore Hospital. And with me today, my friend and colleague, Professor Claudio Tondo from the University of Milan, Monzino Hospital. Hi, Claudio. Today, we are going to be discussing a very important topic, which is reducing or eliminating fluoroscopy for the treatment of arrhythmias. Professor Tondo in Milano has developed with his team a very nice workflow, and he will share with us some data about their experience. So Claudio, the first thing I would like to tell you is reducing fluoroscopy or zero fluoroscopy is a debate to discuss. And number two, why this is so important.
Thank you, Luigi, and hello, everybody. Yes, I do really believe that reducing the X-ray exposure is really a critical issue, because it's not beneficial to patients, but also for all the people around in EP lab, allied professionals, physicians, and technicians. And we have been starting a few years ago just to use the zero or near zero fluoroscopy guidance for catheter ablation by starting doing procedure for a simple procedure like nodal reentrant tachycardia ablation or WPW patients. And then once we became much more expert in using the approach, also we jump into AFib ablation as well, and more complex atrial arrhythmias. So I think that this is has become already a conventional quote unquote approach in patients in our lab, at least for supraventricular tachycardias.
Yeah, I think that the learning curve for supraventricular tachycardia is a little bit easier than, of course, doing left-sided procedure with the transeptal, double transeptal sometimes. But the possibility is there. I think technology today is helping us with a very accurate 3D mapping system. And I would say the use of intracardiac echo. I mean, I know in Europe, not many people use intracardiac echo that often. But I feel that the use of intracardiac echo and cartosound, at least in my personal experience, has allowed us, because the near zero fluoroscopy, no fluoroscopy, start from access. We get access with ultrasound. We navigate the wire with ultrasound. And then we go for a 3D mapping system. And then everything is possible with the reconstruction of the 3D. The question before you show us some slides, Claudio, is do you really need to have zero, or having like a little bit of fluoroscopy is important? Because I feel that, the new generation of fellows that have been trained without fluoroscopy, they really don't want to use it. And I see that they can do it. And I really can't do zero fluoroscopy completely, because sometimes I feel I need to check even for 1 second with my fluoro. And I have found sometimes that minimal fluoroscopy can avoid a possible mistake. So what's your take on that?
A very good point. I take this point because you're right. The young fellows or the young EP physicians are much more prone to use zero fluoroscopy. Probably are, they are much smarter than myself, or than the senior EP guys. I'm not so obsessed to achieve a complete zero fluoroscopy. You're right. I mean, just even for a few seconds, I think that it's not a big deal. So I am much more a believer of near zero than a complete zero, because I don't think that the near zero can really impact on the total X-ray exposure at the end of the day. You mentioned the even the puncture, the vein puncture with the ultrasound, and this is really a very good way to puncture the vein to reduce the likelihood to have the vascular complications as well. And already we use this approach in all patients. The ICE, the intracardiac echo, actually is much more used for left side catheter ablation, and I have to say that when we use the ICE just for the right side, it's very uncommon. Therefore, if we do a binocular re-entry tachycardia or a supraventricular tachycardia in young patients, actually a very short time of fluoro can be done on my view, just to make sure that we have the right position and obviously avoid maybe just a mismatch with the 3D mapping. So just to summarize my position, I'm okay. I had to change my approach in the last few years and convert myself into non-fluoroscopic 3D mapping guidance. But still, I like just to have my my foot on the X-ray pedal if I need it.
Okay, so probably is I think the way you train your brain is like when you drive a car. If you learn with the shift car, it's very hard to go to automatic. At some point, you will be able to shift from one to the other, but at the beginning, you're gonna feel a little uncomfortable. But we have agreed that minimizing fluoroscopy is absolutely a must because we need to protect ourselves and our patients. And the technology that we have today that go from 3D mapping to intracardiac echo allow us to really reduce to the max, if not to zero, the exposure. Would you like, Claudio, to share with us your personal experience with your team in Milano?
Okay, just a few slides just to underline actually the data that we can collect from the literature. The majority of the data that we have been collected from experience or single center experience, but already we have data from multi-center or meta-analysis that I will show just in a few seconds. And catheter ablation, already I mentioned binocular re-entry tachycardia without fluoroscopy is feasible and safe. I think that these two principles are very important because we need just to keep our safety profile very high, and at the same time to be very effective and successful. Okay, we just mentioned the non-fluoroscopic 3D mapping. This is just one of our experience. Actually, there was an experience combining a patient coming from our institute and also from Austin and in New York, showing the use of the Navic system just in this specific case. And as you can see from the slide in the right end of the slide, you have this nice 3D reconstruction of the four cardiac chamber, and obviously you can move, you can navigate into the 3D mapping safely, and then you can map and you can ablate. Next slide. I think that in here also we have other data, and it's not just to to show that the upper end of the right end of the slide, you have this green bar showing how I mean just the concept of minimally fluoroscopic approach in EP lab has grown in the last few years, and here we have the experience. Actually, also Luigi and myself are among the authors, and this is I like. I mean, just the the definition of the growing culture, of the minimally fluoroscopic approach that has been expanded in the last few years. And here we have data from multi-center experience or single center experience. I mean, already many EP labs have adopted this approach, and also the data from the literature has been corroborated from meta-analysis, and here we have the quite recent meta-analysis in 2021, in which there was a demonstration that the minimally fluoroscopic approach can be obviously beneficial to patients, also in terms of acute success rate, in terms of complications, and in terms of recurrence rate. We have a slide showing three tables. I think that this is, can be considered a very good summary of our concept. At the left end, the success rate, and if we take into account not only randomized studies, this is the first list of studies, but also non-randomized studies. All these studies actually show that there is a favorable clinical outcome for non-fluoroscopic guidance as opposed to fluoroscopic guidance. And this is true also for complications. And you see that even for complication, there is a tendency to be reduced when there is a minimally fluoroscopic approach. And in terms of recurrences, here the data actually are quite similar. In some studies, there is a tendency to have less recurrences when a conventional, that means by using X-ray, has been used as opposed to non-fluoroscopic guidance. But really, surely, I do really think that the recurrence rate are very similar, pretty similar. Next slide. I don't remember if this is the same. And here, actually, there is a data coming from the pediatric arena, and obviously the chance to reduce X-ray exposure in children or in young patients, in adolescents, is really critical. And from the pediatricians and from the pediatric EP physician, we have a demonstration that the use of 3D significantly improves the success rate for Wolff Parkinson White children, and the acute success rate is fairly the same, or maybe in some studies superior to the use of conventional. And here just another example how it's possible without X-ray exposure to reconstruct in a 3D modality the vein and the cardiac chamber, and obviously again how to navigate and how to map and ablate.
Yes, so Claudio, thank you so much. I think you show this is possible, you show data, you show safety, you show feasibility, you show the good outcomes. What is your recommendation for the audience in if people are not doing now? What is the number of cases they need to do, and what is the learning curve to move from using fluoroscopy to not using fluoroscopy? What is your advice for them?
Thank you, Luigi. Well, it's just a progressive way to switch from a complete fluoroscopy guidance to minimally fluoroscopy approach. If I have to give a number, in our experience, and again, young fellows are are much smarter than the senior, because maybe in 10, 15 procedure already they can easily move the catheter from the vein to at least to the right side of the arch, and probably I would say maybe the 20-25 procedure are enough just to be safe. And we encourage our young fellows to do that, but also how to to check with the fluoroscopy, and trying, for example, not not use the left oblique projection, which we know that is not really beneficial to physician to patient. So we try just to keep very few views when the fluoroscopy, the X-ray need just to be used. But just to answer your question, I think that around 20-25 procedure just enough for young fellow to I wouldn't say to master the procedure, but to become familiar with that, and then I mean just they can do it safely.
I agree with you for right side procedure. You don't really need the intracardiac echo all the time. Although in US we have it and we use it, but you don't really have it. With minimal fluoroscopy, the procedure can be done. But always remember, there's a patient there. It's not a video game. So if you have any reason that you want to check with fluoro, you should be able to do it and use it at some point. For left-sided procedure, we truly recommend the use of intracardiac echo that we actually use not only for the access, but also to navigate the wire, because you can see the full wire going from the IVC to the SVC, and you can do a sheet exchange with the view of the SVC. Then you can perform a transeptal puncture with any technology, and even if you want to use a radiofrequency needle or a wire that goes through the septum and see your sheet in the left atrium, and then reconstruct the 3D mapping system. At that point, once you have the 3D mapping system reconstruction, then of course almost everybody has moved to minimal fluoroscopy by doing and performing the ablation in the left side, guided by the 3D mapping system that give us a 3D view. So I think this topic is important. We want to protect our patient and ourselves. And I thank everybody for being here today. And I thank you, Claudio, for sharing with us your experience on this important topic.
Thank you, Luigi. Thank you for sharing with me this experience.